For the next session, we are going to open the Pandora's box, talking about regional anesthesia applications for abdominal surgery. We are fortunate to have with us Dr. TVS Gopal.
Can I have my slide, please? The slide? Yep. Yes. Good afternoon. Welcome again to this session. It was an honor taking my certificate and memento from Deep. He was a senior resident in PGH Chandigarh when I was a junior resident, and I can proudly proclaim that I learned a lot more from him than my consultants over there. I have 15 minutes to speak on abdominal surgeries, the Pandora's box. So I'll just run through my slides and give you a brief overview. As per Greek mythology, Pandora was a very inquisitive woman. Despite instructions not to open the box, she went ahead and opened it, and once she did that, all the evils that were contained in the box, they escaped. Only one evil remained by the time she shut the box again, and that evil was hope. So, colloquially, when we say Pandora's box, we are referring to something with multiple possibilities. The abdomen, as we know, houses several vital organs and organ systems, and when pathology afflicts any of these organs or systems necessitating surgery, there could always be a twist or a surprise in store for the operating surgeon, hence the reference to Pandora's box when we talk of surgeries involving the abdomen. The surgeons, they resort to utilizing several incisions to gain access to the abdomen when they operate on the abdomen. And in the post-operative period, the trifecta that anesthetists seek to achieve is effective analgesia, early mobilization, and early recovery of gastrointestinal function. Secondary to surgery, there is tissue trauma, as we know, and this sets off a complex series of inflammatory and neurohormonal responses. One of the tenets to ensuring that the patient does well without going down in the post-operative period is to have effective analgesia. And for several decades today, the epidural analgesia has been the gold standard. You can perform an epidural with just a single injection using either the midline or paramedian approach. Bilateral coverage and multidermatomal coverage is assured, and so also is somatic and visceral analgesia. And depending on the extent of incision, we tend to use either a mid-thoracic or a low-thoracic epidural. The benefits of a properly placed and working thoracic epidural are very well known. There are several level 1 benefits that include effective analgesia and a reduced incidence of complications involving various organs. One of the benefits is that a good epidural, a working epidural, prevents progression to chronic post-surgical pain. And today, there is an overwhelming body of evidence, a strong hypothesis that is emerging to suggest that our choice of perioperative analgesic techniques can alter outcomes in patients undergoing onco-abdominal surgeries. But then, a thoracic epidural is probably not permissible or technically challenging in a certain group of patients. You can have failure because it calls for some amount of expertise. It also has its own set of complications, and the popularity of laparoscopic surgery is severely curtailing the practice of thoracic epidural analgesia. The thoracic paravertebral space Shiva spoke about and also demonstrated the approach in 2 levels this morning when doing the live block session. This is an equally invasive yet effective block. As far as the utility of a thoracic paravertebral block for providing analgesia following thoracic surgeries is concerned, there are no questions. But as far as thoracic paravertebral block for abdominal surgeries are concerned, there are certain questions that still remain to be answered and certain practices that still remain to be standardized. The concept of regional anesthesia for surgery of the abdominal wall is not new. It dates back to 1941 when Thomas Selden published this article in the Mayo Clinic Annals. The triangle of Petit, or the inferior lumbar triangle, came into prominence because this is a weak spot through which a herniation could occur. In 2001, in a correspondence to the Anesthesia Journal, Ruffy, an anesthetist working in Limerick, the Republic of Ireland, spoke of an approach to an abdominal field block via the inferior lumbar or Petit's triangle. And it was these three landmark papers in the year 2007 that actually triggered the birth or a spurt in the practice of interfascial plane blocks. And after these papers were published, the most popular interfascial plane block of those times was the transversus abdominis plane block. Now, if you look at this picture, one half of the anterior abdominal wall is innervated by anterior and lateral cutaneous branches of intercostal nerves T7 to T11, the T12 intercostal nerve, which is also called the subcostal nerve, and branches of L1. We do know that these intercostal nerves course in a plane that we call the tap in between the internal oblique and the transversus abdominis muscles. When we count these muscles, it is always good to count from within outwards, because in an obese patient, the scarpas and Camper's fascia would almost look like a muscle, and you could be injecting into the wrong plane. As we all know, these blocks, the TAP blocks, they provide good somatic analgesia. They're quite easy to perform, do not have a very high rate of complications, and they definitely add a new dimension to the multimodal analgesic regime. Now, this green hypothetic line connects the xiphisternum to the iliac crest. And if one were to deposit drug in the tap along this line, you would ensure analgesia from the xiphisternum to the pubic symphysis. But practically, this is not possible, which is why you have several variants of the tap block. You have the rectus sheath, the classical tap or the lateral tap, the oblique subcostal tap. This is the subcostal tap. This is the oblique subcostal tap. And finally, you have the tap, the block that targets the ilioinguinal and iliohypogastric nerves. A rectus sheath block was demonstrated this morning very well by Sishir. Now, a rectus sheath block is useful for midline or paramedian incisions that lie within the extent of the rectus abdominis muscle. So this would be one indication for performing a rectus sheath block. But I dare say that the rectus sheath block would not act below the arcuate ligament, because below the arcuate ligament, the posterior rectus sheath is deficient. Now, this is a fairly innocuous muscle. Before 2007, I don't think anesthetists ever knew what a quadratus lumborum muscle was. And this muscle came into prominence in 2007 with the exposition by Rafael Blanco at 2 meetings in the UK and in Europe. And in his honor, this block was named the Blanco block. It was said to be different from other interfascial plane blocks involving the abdomen because it provided both visceral as well as somatic analgesia, and visceral analgesia was facilitated because of rostral spread to involve the thoracic paravertebral space. Now, the posterior muscles of the abdominal wall include the psoas major and the quadratus lumborum. And as you can see here, these two muscles lie anterior to the transverse process. That is why they are called hypaxia. Now, these muscles are enveloped by a fascial sheath called the thoracolumbar fascia. So the tri-layer model would say that there are three layers: the posterior layer, the middle layer, and the anterior layer. Now, the thoracolumbar fascia is a scaffold. It is part of the myofascial girdle that invests the torso and is important for load transfer, for posture, and stabilization of the lumbar spine. It is rich in nociceptors, mechanoceptors. There are certain sympathetic nerve fibers which are amenable to blockade by a local anesthetic. There are cranial as well as caudate extensions. Now, the anterior thoracolumbar fascia, it communicates with the endothoracic fascia of the thoracic paravertebral space via the lateral and medial arcuate ligaments and also the aortic hiatus. And caudally, the anterior thoracolumbar fascia is continuous with the fascia iliaca. Now, as we all know, there are three approaches to the quadratus lumborum block. The QL1 is now called the lateral block. The QL2 is the posterior approach, which preferentially targets the lift or the lumbar interfascial triangle. And QL3, as espoused by Hans Borglum in 2013 by his shamrock technique, is a transmuscular QL or the anterior QL. Now, this is a variation of the QL, which is the paramedian sagittal subcostal block. This, as you see, the probe is placed in a paramedian sagittal plane over there. This ensures rostral spread to as high as T6. Now, these group of authors in 2021 came up with this particular new block, the external oblique intercostal block, based on anatomical evaluation of spread in cadavers and a brief case series. We demonstrated this block today, and if one deposits the local anesthetic in between the external oblique muscle and the external intercostal, as Sishir showed to you this morning, in between the 6th and 7th ribs, about 20 mils of local anesthetic will be able to block both the lateral as well as anterior cutaneous branches of these particular intercostal nerves. This is a recent publication of our experience with one patient who had an open cholecystectomy. Now, this is a new modification which is called the M-TAPA, in which the undersurface of the 10th rib is professionally targeted as the endpoint for injection. Now, the erector spinae plane block, this block caught the imagination of anesthetists worldwide like no other block in the recent past. And for abdominal surgeries, it is advised that we perform the ESP in between T8 and T11. But when you look at a meta-analysis of the effectiveness of an erector spinae plane block for abdominal surgery, though the opioid requirement and time to first analgesics were fairly delayed, the pain scores and the incidence of nausea and vomiting did not really significantly differ. And I dare say that because the mechanism of action of an erector spinae plane block is still in the realm of conjecture, as I said a while ago, we cannot be sure that an erector spinae plane block will work for anterior abdominal surgeries on a consistent basis as of today. And to conclude, today, anesthetists are looking at a Pandora's box when they look at postoperative analgesic options after abdominal surgery. But that said, even despite the fact that we have so many blocks that are disposer. The selection of the right block in the right patient coming in for the right surgery would be the mantra for success. Thank you.
Can I now request Dr. Anil Sharma to kindly take over the session as the moderator? I'm also inviting the other panelists, Dr. Divesh Arora. From the surgical specialties, we have Dr. Neeraj Chaudhary. Kindly proceed to the dais, sir. And Dr. Suman Mehla, ma'am. And Dr. Ramesh from physiotherapy.
Down. Welcome esteemed panelists, and thanks Dr. TVS Gopal sir for a very broad overview of all the abdominal blocks that are possible. Divesh has been my senior, like what you told for Deep sir. So it's maybe generations on, that is the thing. So let's start the real-time scenarios, and this question is to Dr. Neelam. Now, what is your experience regarding the post-operative pain in TLH? Oh, that's Suman. Oh, right. Yeah. Yeah. You. So, Dr. Suman, what is your experience regarding this?
Post-operative pain. It's working? Yeah. Post-operative pain after TLH. Yes, it is there. Patient do come pain in abdominal area or where the stretches have been put. But with Dr. Anshuman, they have started giving tap block. So now the relief of the pain is very much there, and we do have a very improved pain score after giving that tap block post TLH.
So recently, like the era of minimal invasive surgeries, the surgeries have been taken over by robots. So per se, like how does it changes from total laparoscopic to robotic hysterectomies, and whether that has contributed in reducing the post-operative pain?
Yeah, in robotic surgeries, the plane of dissection is very fine. The tissue injury is less. The post-operative trauma during the surgical part is, the operative trauma during the surgery is very less. So the patient is free of pain. It has more improved pain score after robotic surgery. And the ambulation of the patient is much earlier as compared to the normal TLH.
So Dr. Divesh, like your hospital is now coming up with many robotic surgeries, and like when you go into a robotic surgery, especially robotic hysterectomies, what is your plan of analgesia?
So it's general anesthesia with multimodal analgesia with port site infiltration, what is present state what we are doing, and multimodal analgesia involves PCM, NSH if they are not contraindicated, and IV dexamethasone and magnesium sulfate, plus opioids are reserved as a rescue. And since robotic hysterectomies involve more port insertions as compared to laparoscopic, so port site infiltration is what we are following.
So simple port site infiltration with multimodal anesthesia. So coming to like what you mentioned, opioids. So what is your experience with intrathecal opioids in lap, abdominal and pelvic surgeries?
So we had one visiting surgeon, very great one. So he used to come from Pune to do surgeries and all. He was a big fan that we should give intrathecal, like spinal anesthesia, low volume, along with opioids. He was of the opinion that it gives me a good contracted breath and I can operate much better. But the problem that arises is like the moment you give spinal, then you give general anesthesia and give steep head load. The blood pressures used to fall like anything. So you stop coming first, so we are not using that practice, but it can be thought of. Instead, give 1 or 2 ml of local anesthetic with 100 micrograms of of morphine could be thought of. I'm not doing it, but it could be thought of as
So did that reduce the total consumption of opioids overall?
Intraoperatively, like pressures used to fall. Then we had to give sometimes norepinephrine boluses also. But otherwise, the requirement of muscle relaxant was almost nil for the 2 hours or 3 hours surgery. And post-operatively, patients used to feel much better.
So, Dr. TVS sir, will any block cover this pelvic visceral pain due to robotic hysterectomies or surgeries like that?
Not really. I mean, none of the interfascial plane blocks that we do today would cover the pain arising from the pelvic splanchnic nerves. Chronic pain physicians, they do a blockade of the inferior hypogastric plexus. I have not done this procedure myself, but I think a sacral approach to the ESP would work. Devesh?
What's
any
your
comments?
opinion, Divesh, regarding this?
So I'm a big fan of ESP. So sacral ESP can work because of the anterior diffusion and the hypogastric plexus located quite close by. It can work. So we have used it for pelvic acetabulum fixations as well. That is a bony surgery, but I think it can be tried out.
Right.
Pilonidal sinus we are routinely using, which is a surface surgery, but it can be tried out. It will diffuse towards hypogastric.
So normally we have seen certain conditions where we have to give general anesthesia for cesareans, and this is one such case. So the case was done under GA, and baby was delivered through the fennel seal surgery incision. So Dr. Suman, how does this pain affect mothers and the newborn after cesarean?
Yeah, pain is a very important factor after the cesarean section in deciding when the lactation will start in the patient, because if there is a better pain relief, the patient is able to hold the baby sooner. She is able to latch the baby, and that helps to initiate the lactation in a better way. Secondly, early ambulation is also a very good thing if the patient is totally relieved on pain. That helps us in early embolization and control of PPH, because the uterus contracts more, and the well-being of the patient is obviously better after once she is adequately pain relieved.
So have you noticed any difference in these patients once the regional anesthesia techniques were used in the...
Yeah, there is very much difference between the two, whether when general anesthesia is used and when the regional anesthesia is used. But obviously, what we used to do earlier is to supplement the incisional site with the local anesthesia. But with the tab block coming up, I don't find much of a difference after the tab block is being given.
So you have modified the practice accordingly?
Yeah, yeah.
So Dr. Divesh, in this particular patient, what would be your plan of analgesia post-op?
Okay, as this patient has a low platelet count, like 45,000 as you mentioned, so I would not like to go for a quadratus lumborum block, because this being a deep block, and in patients who have low platelet counts, it should be avoided as per the recent guidelines from European Society published in 2022. Whereas TAP versus ilioinguinal iliohypogastric, they are superficial blocks. They can be done in patients with low platelet counts. In our institution, it's our standard practice to give TAP blocks or transversalis fascia plane block for LSA. So I would like to go for TAP block in this case.
Right. So Dr. Ramesh, you would have seen these patients after spinal anesthesia, and most of them are still jittery, power nahi aaya hai, pair hill nahi rahe hain. So how do you plan physiotherapy in these patients after spinal anesthesia?
Sir, even though I personally don't treat any LSCS patients, the female physiotherapists who go there,
Yeah.
but generally after 24 hours, we are asked to mobilize the patient. But one question I would like to ask anyone if you can answer. Recently we had a patient who had undergone an abdominal surgery, and we were asked to mobilize the patient. When we examined the patient had weakness of the hip adductors, and there was a slight sensory impairment in the anteromedial aspect of the thigh. Can anyone explain what was the possible cause for this?
Dr. TVS, sir?
No, did this patient receive a block during the procedure?
I'm not sure, sir. It was a post-abdominal surgery patient.
Okay. See, if the patient had a quadratus lumborum block, there is quite a significant correlation between quadriceps weakness that is associated with an anterior approach to the quadratus lumborum block. But if a block was not performed at all, it could be positional. And sometimes we have seen that following a spinal anesthetic, certain segments take much longer to revert to normalcy than before. It could be with the multiple attempts that have been taken while performing the spinal owing to a difficulty, in which case you could expect certain of these transient neurological symptoms in the postoperative period, which typically resolve within a week or so. Did it resolve in this patient?
The patient was an international patient. She had to fly back. So she was here for around a week to 2 weeks' time. She was recovering, but we couldn't see the end result.
Okay.
So certain patients of abdominal surgeries are receiving anticoagulants. So in such patients, what is the plan of postoperative analgesia, Dr. Divesh? Patient coming for abdominal surgeries.
First of all, with patient receiving enoxaparin 40 mg BD, I think even the surgeon and we would like to wait another 24 hours to actually operate. This is almost a therapeutic anticoagulation. So drug levels would have gone down if we are operating. If we have to operate on this level, it's like, so I would like to go for a superficial blocks, like rectus sheath, depending on the kind of incision is there. So for abdominal, neuraxial is completely contraindicated, paravertebrals are contraindicated, and in terms of facial plane blocks, quadratus lumborum as well as fascia transversalis is also contraindicated. So what I am left with, if it's a midline, imagine from T6 till L1, 4-quadrant rectus sheath block would be a good choice.
Do you concur, sir? Dr. TVS, sir?
No, I don't. Unless 24-hour window is there, since cessation of the last dose of enoxaparin, I would not do a block.
So the take-home message is that we have to be very, very careful while planning for surgery as well as blocks in such patients receiving.
Absolutely. When you do a rectus sheath block, actually Shishir mentioned this morning that you could have the inferior epigastric artery in that plane. And the tap plane is also not devoid of any vascular elements in that plane. There have been instances where there have been hematomas following a tap block also. So I think it is better to be safe rather than adventurous and sorry. So if a patient is receiving therapeutic doses of low molecular weight heparin, it is always good to give a 24-hour window after the low molecular weight heparin has been stopped.
Right. So this is another patient like the surgery was a Mercedes-Benz incision and posted for Whipple's procedure, Angst-Bond with difficult spine. So what is the plan of post-op analgesia, sir, in these cases?
Epidural is definitely ruled out. A thoracic paravertebral block is still possible. So I would definitely want to do bilateral thoracic paravertebral blocks in these patients. Now, another option in these patients would be to do bilateral external oblique facial plane blocks and combine them with bilateral rectus sheath blocks. But that would entail giving huge volumes of local anesthetics. So my primary preference would be to do bilateral thoracic paravertebral blocks, single shots.
Right. So, Dr. Neeraj, as we all know, like ERAS is coming up in a big way. So, what is your experience with the anesthetists intra giving IV opioids?
Yeah, first I will go to the back question which
Yeah,
you
please.
asked regarding the enoxaparin.
Yeah, yes, sir.
I think until it is an emergency surgery, the surgeon should not post that case. Forget about the anesthesia itself. we should not consider even anesthesia or any blocks until and unless that is an emergency surgery, because it is therapeutic anticoagulation. So definitely the opioids interfere in ERAS pathway, that is well known and proven in all the studies. Opioids have significant side effects in terms of gut motility. They cause nausea, vomiting and ileus, and therefore ERAS pathway is only based on early recovery. So early recovery is hampered because in all the surgeries, what we are looking at in abdominal surgeries is how early the gut recovers. The gut recovery is a problem with opioids, and therefore the opioid sparing anesthesia is more and more preferred nowadays, and so that opioid sparing effect is there.
So what is your experience of like regional anesthesia, whether this has hastened the recovery, or you are able to mobilize the patients early whenever your patients are subjected to regional blocks instead of opioids?
If we see the ERAS, early recovery after surgery, I believe only 3 things have happened in the past 1.5 decade, which has hastened the recovery of the patient. I think 3 points of the take-home message is: first is goal-directed fluid therapy. Second is BIS, that is monitoring of the anesthesia, the level of awareness, and thereby reducing the amount of anesthesia intraoperatively. And third is regional anesthesia, that is epidural analgesia or nerve blocks. These are the only 3 things which are important and helped in patient recovery and ERAS pathway. So therefore I would, on all our patients, or of all the abdominal surgeries posted, our team is taking, Dr. Anshuman and team are usually in all the patients without any group, they give anesthesia, epidural or regional anesthesia is given in all the patients without any hassle, so that the recovery is better in the post-operative period. The patient ambulates. As soon as the patient ambulates, the chances of deep vein thrombosis, respiratory complications, gut mobility, everything is better, and the patient goes home better. Only in terms of surgical, I would say more and more patients we are doing by minimally invasive techniques. So laparoscopic and robotic surgeries definitely have decreased the amount of anesthesia which has to be given, and the post-op recovery is better.
Thank you, sir. So, like Dr. TVS told beforehand, that bilateral EOI may be one option in this cases. Any facial blocks, plain blocks, sir?
Theoretically, it is possible. You can do a 4-quadrant tap, but then doing 4 different injections, putting in large volumes of local anesthetics, and if you have to put catheters, then you are looking at 4 syringe pumps. So I don't think that would be a feasible option. Bilateral external oblique, intercostal facial plain blocks, we've been doing quite a few in the recent past. We've also made a practice in liver transplant recipients in the last 6 months. And we do single shots. I have no experience with catheters, but that said, I'm sure catheters can be placed.
Right.
And because they are going to be inserted just above the rib cage, anchoring the catheter should not be a problem.
Right. So many times we have seen that the laparoscopic cholecystectomy had to be converted into laparotomy. And so what is your experience regarding post-op pain in patients following open chole?
Obviously the pain will be much more than the laparoscopic one. And the things which may help in these patients is immediately after the conversion happened for some reason, bleeding or anything else. So they should be given peripheral nerve blocks after the completion of surgery. And sometimes if the injury of the bile ducts or something has happened which has resulted in conversion to the open cholecystectomy, I think post-operative epidural also would help.
Right. So do you concur, Dr. Divesh, what we'll do for such cases?
Definitely we need to offer some analgesia because we have converted from a laparoscopic to an open procedure, and subquestal incisions are quite painful. So as sir has already mentioned, the EOI is a good block which will target our lateral cutaneous branches as well as anterior cutaneous branches. So it can be done easily in the post-operative period because it is at the level of 6th to 7th costal cartilage. And the incision is much below, the dressings do not interfere in the block performance. Catheters can be easily placed. And for Whipples also, if the coagulation is borderline, like INR is 1.7, 1.8, where we cannot do epidurals, so we definitely put in bilateral EOI catheters.
Right. So, Dr. TVS sir, what about EOI with the rectus sheath in this? Only left or bilateral?
I would do only open chole, right? So the primary choice would be to do an epidural after the surgery is done, before we wake up the patient. This is because with the external oblique intercostal facial plane block, you will get somatic analgesia. But after the gallbladder has been removed, the liver bed that is raw and has been coagulated with cautery, that is innervated again by a branch of the phrenic nerve. So if you want total analgesia, it has to be a thoracic epidural. But if that is considered to be too extreme, lots of times the surgeon says, don't do an epidural at the end of surgery. So the other option would be to do a unilateral EOI block.
Right. So how important is the role of early physiotherapy in these major abdominal surgeries?
So early mobilization is very important in any patients who undergo any type of surgery, not left over this abdominal surgery alone. But having said that, to prevent any respiratory complications in patients with other, like COPD and other patients who undergo abdominal surgeries, early mobilization is very important, and preventing other complications like DVT and things. So a patient is very happy, especially to go to the major thing is bed mobility and going out to the washroom and coming back. That's a major thing. So the second question, pain management.
Yeah.
If the pain is managed well, most of the activities, mobility and exercises can be done well by the patient. So if post-operative pain can be taken care of with some low dose, I'm not an expert in that. If that can be taken care, it plays a very important role. If anyone can tell that in detail, that would be better.
Right. So in nephrectomies, we have seen, though the donor nephrectomies are mostly laparoscopic nowadays, but for other reasons, if the nephrectomies are done, the 12th rib is resected by surgeons sometimes. So it's an hockey J-shaped incision. So in these cases, what will be your post-op management strategy, sir?
My pre-op management technique would be to site an epidural. Because donor nephrectomy with or without resection of the 12th rib causes significant pain, and we must remember that a patient who is coming in for a donor nephrectomy is not a patient, he is a normal person. He is giving away an organ for a philanthropic cause. So ensuring good analgesia for these people in the post-operative period is very important. So I would place a thoracic epidural pre-op. The other two options would be quadratus lumborum block, but as I showed in one of my slides, it could be a sagittal subcostal approach, because you would have analgesia going up to T6. And the third option would be to do a thoracic paravertebral block, because that would be done higher than the area of the resected rib. So that should not be a problem. But that said, my first option would be to do an epidural.
So we are giving a lot of midline incisions are happening in abdominal surgeries. So above umbilicus bilateral rectus sheath block, is it okay, Dr. Divesh?
I think we need to decide whether we want a somatic analgesia, visceral analgesia combination, or alone somatic. So as Dr. Gopal has already said, the majority of the facial plane blocks, except for the fact of quadratus lumborum, will only give somatic analgesia. So they will not offer visceral. Quadratus lumborum can offer a visceral analgesia in addition to somatic. So if my target is only somatic above umbilicus, then bilateral rectus sheath is going to be my choice.
And quite often, like when we have to extend the incision, sir, above the planned or below the planned incision, Dr. TVS, sir, what about the 4-quadrant tap? How often do you use it?
Now, I was at this ISURA conference in Germany in 2009. That was when TAP was the a very, very popular block. And Dr. Peter Hubbard had spoken about doing 4-quadrant TAP and putting in 4 catheters and sending home the patient with 4 syringe pumps. I think that is an overkill. First of all, it's a lot of local anesthetic. Second, it's a lot of consumption of resources. I would not suggest a 4-quadrant tap. A bilateral rectus sheath block, if that is what we can do in case an epidural cannot be placed in this patient, would be an option. I would not want to advocate anything more.
So, Dr. Neeraj, you would be...
Let me add,
Yeah, please.
sometimes it happens, like we have thought of a laparoscopic abdominal surgery, and suddenly they need to
Convert into
a extending from T6 till pubic symphysis. So what we do is we calculate the upper limit of the local anesthetic. So we take 20 in a bowl, we take 20 ml of 0.75% propiocaine, 20 ml of xylocaine with betadine. That gives the maximum dosage for a 60 kg individual. Plus add 40 ml of normal saline. So this makes, along with dexamethasone 8 mg, this makes 80 ml of the local anesthetic solution available to you. So in upper quadrants, we do bilateral rectus sheath. And as said in the morning, like inferior to arcuate line, the rectus sheath is deficient. So we are not guaranteed of whether it would block the nerve segments. So in that case, we do a bilateral anterior tap. Nowadays, the anterior tap terminology is not being used. Just before their entry into the linea seminaris, we block. So upper quadrant rectus sheath 20/20 and lower
segment.
And we do single shot. We do not place catheters because it would amount to a huge volume of local anesthetic and certainly will be knocking at the doors of last happening to us. So single shot, it helps. It has helped me in so many, because these days surgeons definitely would like to put in a scope first and then
Extend that.
decision for emergency kind of
Yeah.
situations.
So, Dr. Neeraj, bariatric surgery patients, like how soon you want to mobilize them in your
I
experience?
think all these patients are done by minimally invasive techniques. And forget any surgery, any bariatric surgery, for all surgeries, we mobilize the patient as soon as possible is the criteria.
Yes.
And that criteria usually depends on how the anesthesia was given. And usually all these patients can be mobilized after 6 hours. So as soon as possible is the criteria. If they are well off, there is no other problems, hemodynamically stable, I think after 6 hours they are ready to move out of the bed.
And what are the challenges in physiotherapy in such patients?
No, I tend to agree with him.
Yes.
We are a fairly high volume bariatric center. We do about 15 to 20 bariatric surgeries a month. Just yesterday we did a patient with a BMI of 68.6. We do mobilize them by 4 p.m. in the evening. We make them walk to and fro in the SICU. We seat them up in these special chairs which are huge. And as far as possible, by about 6:30 or 7, they are back in the room.
So, what is your plan of anesthesia in these patients, bariatric surgeries, Dr. Devesh?
So first is standard multimodal anesthesia, and for abdominal wall, because it has been, ports have been inserted, tap.
Right. And will QL block lead to quadriceps weakness in these patients, Dr. TVS, sir?
Yes, I said this a while ago. When you do an anterior QL, we do know that the anterior thoracolumbar fascia is continuous caudally with the fascia iliaca. So there has been nearly a 20% incidence of quadriceps weakness when an anterior QL has been performed.
So there is a definitive risk and we need to be careful while.
Absolutely, especially if you want to mobilize the patient in the immediate post-operative period, you have to assess the integrity and the strength of the quadriceps before you start to mobilize them.
In fact, if you look at it, anterior quadratus lumborum block through shamrock approach is being used for hip surgery also.
Right.
So there are chances of it producing weakness. So we have to be careful whenever we give anterior quadratus lumborum block for abdominal surgeries, that it can lead to the quadriceps weakness as a side effect.
So coming to this last patient of ours who is a BMI of 50 and severe OSA for obstructed inguinal hernia surgery. So what will be your analgesic plan in this particular case?
BMI of 50, severe OSA, obstructive inguinal. The safest would be to do, ask my surgeon to give a good local infiltration. The second least invasive option would be to do an ilioinguinal and iliohypogastric nerve block, but that said, in a patient with a BMI of 50, to be able to identify the plane and identify the nerves is going to be a huge challenge. So I'm not too sure if I can suggest any block that will definitively work. So I would request my surgeon to go ahead and give a good local infiltration.
I think I'll have a discussion with the surgeon regarding the plan of surgery. So if I can feel the spine and we can do the entire surgery under a combined spinal epidural and I'm able to insert, I think that would be the best option.
And definitely no opioids in such scenarios. Right.
No, I thought you said analgesic plan.
It was analgesic, but try to convince all the anesthesia and analgesia.
So thanks for giving us a 360-degree view of the abdominal blocks. Thank you.
May I request Dr. Moib Hamidi to kindly help us to felicitate our faculty. First, thanks Dr. Devesh. Dr. Neeraj. Thank you, sir. Dr. Neeraj Chaudhary. Thank you, sir. And Dr. Suman Mehla. Thank you, ma'am. Thank you, Dr. Hamidi.